So my name is Ryan Gentzler. I'm an assistant professor in hematology and oncology at the University of Virginia, and my focus is on thoracic malignancies, particularly lung cancer. So I think immune compromised is a relative term, and that could mean anything from having a lifelong or inherited immunodeficiency or a viral illness that leads to immunodeficiency, such as HIV or AIDS, but can certainly be acquired as well, related to an underlying malignancy or due to treatments that we may deliver that may render an individual immunodeficient. So, certainly, patients with underlying blood cancers like leukemias and lymphomas may have a deficiency in lymphocytes or other immune cells that makes them immunodeficient, regardless of whether they've received treatment or not. In most solid tumors, we think that that's less of an issue, but certainly some of the therapies we use, particularly cytotoxic chemotherapy that can reduce white blood cells, can take a patient who may be perfectly immunocompetent and several days or weeks after treatment, make them more immunodeficient. So I think the answer, we don't necessarily know the answer to that. I think that in general, we think of patients with underlying conditions, heart disease or hypertension or chronic medical issues like diabetes, as being risk factors for general health. And anytime you're sick enough to get admitted to the hospital with those underlying conditions, the complication rate is higher. Certainly, cancer can be one of those underlying conditions. They can make you more immunodeficient, or the treatments that we give can make patients with cancer more immunodeficient and at higher risk for complications. And so I think it really varies depending on the tumor type, the burden of their cancer, whether it's an early stage or metastatic, can be all relative. And I think that there may be patients who have very few underlying medical problems other than an early stage cancer. And I wouldn't necessarily think that their risk would be as high as someone with a long list of medical problems, including cancer or more advanced cancer that has resulted in compromised organ function of some sort. So I don't know that there's any blanket answer to the risk for cancer in general. I think it's really a case by case basis. So I think this is an area of opportunity to really re-examine how we deliver care. We're used to seeing patients on a regular basis, whether that's once a month or once every 2 months when they're on oral cancer therapies. But I think that in the era of COVID-19 and the importance of social distancing and minimizing risk of exposure to healthcare systems and to other patients or potential individuals who may have the disease, patients on oral therapies may be at lower risk of complications because depending on the oral therapy, they may be less immunocompromised as someone getting more traditional IV cytotoxic chemotherapy. And so I think one opportunity here is really just doing more telemedicine and remote check-ins. Patients can sometimes have labs for monitoring the side effects of these oral chemotherapies or oral targeted therapies, and can be evaluated by video conference with their physician, and minimizing their risk because it's not absolutely required that they would come in to get an IV infusional treatment. They could stay home, continue to take their pills, and I think we as a physician community should be striving toward delivering that care with remote contact as much as possible. So I think this is a tricky situation. Obviously, the reasons to avoid seeking medical attention and traveling to a healthcare facility is obviously contracting a potentially life-threatening illness of COVID-19. And I think it depends on the individual's risk in terms of If they were to get COVID-19, what's the risk to them? Do they have the underlying conditions that puts them at a higher risk of needing hospitalization, ICU level care, or potential death? And so certainly those individuals over the age of 65 or those with underlying medical conditions are at a higher risk. And you'd really want to think harder about giving chemotherapy in that setting. That being said, cancer is a life-threatening illness as well, and I think those risks of the two, contracting COVID-19 or letting the cancer go untreated, really depend on the individual case. And I think if you had someone with again a type of a treatment that has been shown to extend the time until cancer recurrence, but it hasn't necessarily been proven to improve the chance of cure or the overall survival, as we call it. Maybe those are less important therapies to deliver in this setting, particularly for those that are at higher risk from COVID-19. Obviously, if you have a potentially curable disease and that disease is a more aggressive type of cancer, there's profound benefits to getting started with treatment for the cancer early. And I think delaying all treatments for all cancers carries significant risk that it's not something we should be doing as a blanket across all diagnoses. So it really depends on the individual. It depends on the risk from COVID in that individual. It also depends on the risk of the cancer and the risk of recurrence or the risk of death related to complications from the cancer itself. So I think this is an area of opportunity where we can delay some of those scans and check-ins, and some of this has to depend on what type of cancer. Certainly, in my area of expertise in lung cancer, there's a fairly high risk of recurrence, and oftentimes the earlier we detect that recurrence, the earlier we can get started on treatment that can get that back under control, delay the onset of new symptoms, and prolong life. So if you have a cancer that has a particularly high risk of recurrence within 1 to 2 years after your curative therapy, yes, I think that continuing to do those scans is important. I think the real question is the interval. And I think most of the guidelines that we have a range of intervals where those scans are appropriate. And if you have a range of 3 to 6 months or 6 to 12 months, maybe you inch toward the longer end of those ranges and delay those scans 1 month or 2 months or 3 months as we get through the peak of the COVID-19 pandemic. And then hopefully it's safer to get those scans in the near future. But I wouldn't plan on canceling those scans altogether and not resuming a surveillance plan. I think of it as a temporary hold and resuming it as soon as possible. But if you get to the sort of upper limits of the appropriate range for whatever situation you're in, um, probably worth it to come in and get those scans. Or certainly, if you start to develop a new symptom, if you start to have unexpected weight loss or fatigue or something that warrants a more urgent evaluation, you certainly don't want to delay those scans.